Good morning. Good morning. Let's get started, please. So this morning we're going to be doing a review of some pediatric cases as we head into the respiratory season. We'll review some of the key diagnoses. Much of this will be some information you've heard before, but we've also got information about some new pediatric infectious disease. Then we're going to talk about Ebola, and then we'll do case reviews. So for our pediatric review, we're going to review the pediatric assessment triangle. We're going to review respiratory emergencies, cardiovascular emergencies, including cardiogenic and septic shock, neurologic with specific attention to febrile seizures. We'll review anatomic and physiologic differences in pediatric trauma, and then go over some items specific to children with special needs. So the pediatric assessment triangle is a tool to help you form a general impression of the pediatric patient. It takes together appearance, work of breathing, and circulation to the skin. I think many of you were trained, as I was, with primary and secondary assessment, and you may find that you subconsciously take this in as part of your primary and secondary assessment. This is another tool that really helps simplify and figure out which directions to go next with a pediatric patient. So the appearance, you can use the mnemonic tickles for tone, interactiveness, consolability, the look or gaze, and the speech or cry. And so any gross abnormality with one of those things is going to require some immediate intervention. Work of breathing, the respiratory rate and effort, and retractions and flarings. I think particularly when you're seeing someone in their home environment, often these kids will be bundled up, they'll be wearing loose pajamas. It can really give you a clue to some subtle respiratory distress, to unzip the pajamas, to look under the shirt, just get some eyeball how significant the retractions are, if they're present, and then the respiratory rate. And the change in the respiratory rate can be really subtle, but it's one of the best indicators of how your treatment is working. And that'll come up with specific diseases that we talk about. And so having an accurate respiratory rate when you first saw them, particularly before they were placed on oxygen, really gives an important clue. Now, obviously, you're going to be doing these things in parallel, but an early respiratory rate and serial respiratory rates is really important. Was there a question in the back? And then circulation, skin signs, color, cap refill. So you're looking for pallor, mottling, or cyanosis. And again, this is a time where exposing as much of the skin as you can, at least temporarily, gives you an important clue. Many times the cyanosis will just be at the extremities. And so maybe I'm just thinking this because I got my kids dressed for bed last night, but a lot of times kids will have jammies with feet on this time of year, and you're not going to notice these abnormalities unless you expose them and then cover them up with a blanket to keep them warm. So the information in the pediatric assessment triangle is going to give you the critical information that you need to determine the pace of the call. It'll allow you to assess ABCs, to intervene on life threats, and to transport. And then if you find that everything is okay with the pediatric assessment triangle, then you have time to go on with a more detailed assessment. So with respiratory emergencies, I'm just going to review some terminologies. So respiratory distress, which in general will qualify as mild, moderate, or severe. That's a very helpful thing to get on the HERE report because it kind of takes together all these different things that you're finding and gives us a picture of how sick the kid is. Respiratory failure is when the child is not able to compensate for the respiratory distress with hypoxia and CO2 retention, and then respiratory arrest. So we'll go into specific respiratory emergencies now. So we'll talk about foreign body, croup, epiglottitis, asthma, bronchiolitis, enterovirus D68, which is something that's caused increased problems this year, and then pneumonia and pertussis. So with foreign body airway obstruction, this is typically something that you're seeing in infants and toddlers, rarely the developmentally delayed older child. So with mild obstruction, you may see stridor or drooling. You may see increased work of breathing, but the skin assessment is still going to be normal. Severe obstruction, the child can become cyanotic or unconscious. And so this is another case where the pre-hospital assessment is so important, because when I'm seeing this child in the emergency department, I have no idea what the home looked like, what was around for him to get into. Now, the history with these is never perfect and it's never clear, but if you see a bunch of stuff around there, that's critical information that helps us think of something that we might otherwise miss. So with responsive infants, back slaps and chest thrusts, if you're removing a foreign body, remove if visible. If not, when someone who's unresponsive, we're doing chest thrusts, CPR, to try to expel the airway obstruction. In children, abdominal thrusts, and then if the child becomes unresponsive, position supine, and then chest compressions. And look with direct laryngoscope and remove with the McGills. Okay. So croup is a very common illness. Viral infection of the upper airway. It's typically a fairly abrupt in onset, and often you'll get the history that the child was just a little bit sniffly, and then tonight really started to have difficulty breathing and this loud cough. And so we describe the respiratory distress with croup as whether they have audible stridor only when agitated or stridor at rest, the barky cough, and occasionally, particularly if you're taking someone outside, they get exposed to the cold air, they may get better and we may not get a chance to hear that cough. So your description of the cough that you initially heard is very important. You'll often see some increased work of breathing, but until very late, these children tend to preserve normal skin color. So management is directed at avoiding the further agitation. If there's mild stridor with agitation, you can use a normal saline neb. The advantage of that operationally for us in the emergency department is that if they have not gotten racemic epi and they're doing well at that point, then we can give them steroids and then discharge them fairly quickly. We will, if someone's gotten racemic epinephrine, we'll monitor them for a minimum of 2 hours to look for rebound or worsening. But that said, if they are having cyanosis, significant stridor, high flow oxygen, and then racemic epi, half a milliliter for a child 20 to 40 kilograms, and 1/4 of a milliliter for a child under 20 milligrams. And under 20 kilograms. And then monitor for the response. I've been misled by this before. Occasionally you'll hear a kid with a cough and they're not moving a lot of air, and then you give them a racemic epi. I had a kid about 2 weeks ago that really looked like croup, and then I gave them the racemic epi, and then they really opened up and started wheezing. And it turned out that it was much more of a wheezing presentation than an upper airway problem. Remember, the racemic epi will work on both, but just monitor for your response and your description, the description of how much respiratory distress, the respiratory rate, those things before the kid had racemic is really important for us to determine the next step in management. So now we're going to talk about epiglottitis, which is an inflammation of the supraglottic structures. So classic, meaning if you haven't been practicing for more than 20 years, you probably haven't seen much of this. So these children with epiglottitis are typically sick, very, very toxic appearing, much different than the child in croup, in a sniffing position, drooling, and they tend to be fairly pale. tends to be a much slower onset. This disease is almost unheard of now that we have the Haemophilus influenza B vaccine. And actually now when we're seeing it, we occasionally see it in adults, either from that or from another pathogen, but it's very, very rare in immunized children. So if you have concern for epiglottitis, again, doing everything you can to calm the patient, assessing the rate and quality of the respirations, and doing everything you can not to manipulate or try to visualize the pharynx. As the treatment, the pre-hospital treatment is the same as for croup, but this is relevant not just to epiglottitis, but to the other things that look like croup. If something looks a little bit out of the ordinary, or it's just doesn't feel like a typical croup case to you, respect that sense, because the tricky part with croup is pulling the needle out of the haystack. Because there are other things like bacterial tracheitis, like a foreign body, that can both present and look similar to croup, and don't do nearly as well as children with croup typically do. So treatment ends for croup, and then if the patient becomes unconscious, going to attempt positive pressure ventilation. These are only in respiratory arrest would you try to intubate a child with suspected epiglottitis. And this is a case where you potentially would need needle cricothyroidotomy if they become unconscious. Yeah, that's a very rare subset of patients with a very rare disease. Okay. Now we're going to move on to asthma, much less rare. Remember that asthma is bronchospasm plus inflammation plus increased mucus production. Different children have different triggers, but we tend to see this more in the winter because there are more viral URIs circulating, and then obviously more cold air. So all of these things can trigger asthma exacerbations. So management with Med-Neb, Solu-Medrol 2 mg per kg. Remember that that's not something that you're going to see results from for at least 4 to 6 hours. But particularly in the case where this person, if the emergency department's backed up, they're not going to be assessed by a physician for an hour. And getting that on an hour earlier definitely is something that will impact their ultimate disposition. For severe exacerbations, magnesium can be very helpful. Pediatric dose is 25 to 50 milligrams per kilogram over 10 minutes. And I've had kids that I was on the verge of intubating and then started magnesium and turned them around. So for severe exacerbations, magnesium is very helpful. It works as a smooth muscle relaxant. And so if status asthmaticus or unable to ventilate, then an epinephrine infusion. And this also can be dramatically effective. And you can have children that look they're like on the verge of intubation, and with an asthma presentation, you really can turn them around. So be thinking a couple steps ahead. Do the MEG first, but then think about in the really sick asthmatic getting epinephrine out. So bronchiolitis is something that we are going to be seeing a lot of, typically in children less than 2 years old. And so you'll typically see some retractions, tachypnea, and the hallmark of bronchiolitis and what differentiates it from asthma or from pneumonia is that you'll hear wheezes and crackles, but they shift when you do your exam. Meaning that you'll hear, so say in the right upper field, you'll hear some wheezes, and then you listen a few minutes later and they're not over there, but they're in the left upper field. And it's because the pathology in bronchiolitis is mucus plugging, and those mucus plugs will shift. And so a fixed wheeze in just one spot is more concerning for pneumonia, wheezing that moves around, crackles that move around are typical of bronchiolitis, and then diffuse wheezing that doesn't change is more typical of asthma. And then you'll typically see some degree of hypoxia with bronchiolitis. So there is a danger of respiratory failure, particularly in cases of severe bronchiolitis. And the people that are at risk for that are in the first few months of life, premature or any pre-existing lung disease, any congenital heart disease or immunodeficiency. And so pre-hospital care, this is, you can think about bronchiolitis as death by snot. It's just so much mucus, both in the upper airways and the lower airways, and that's what makes it more difficult. So you can do non-invasive suctioning, trying to clear up as much as you can of the mucus. Oxygen is key, and then it's a trial of bronchodilation. Only about 20 or 38% of kids with bronchiolitis will respond to bronchodilators. So it's not like asthma where bronchodilators fix the problem, period. And it is really important in determining what their outpatient therapy is going to be to know whether they got better or not with bronchodilation. And so, again, I've mentioned this before, but knowing the respiratory rate, knowing the amount of respiratory distress before they had a bronchodilator and after could potentially be the difference between sending the kid home on this medication and the cost that goes with getting a nebulizer, with getting the medications, and with potentially being on a bronchodilator for some time, versus you could potentially save them something that's not really going to help them. So try it, but document what their response was. And then this is how aggressive we're going to get with the suctioning is something that we'll look at. No change in the protocol right now, but that's something that the pediatricians are really emphasizing with this right now, is that that the suctioning can be really helpful in these children. So enterovirus D68 is not something that you're going to diagnose or treat in the pre-hospital setting, but it's something that's had a fairly significant impact on healthcare, particularly in a few locations. And so I want to give you some basic background on it. So enteroviruses circulate every year, most commonly cause GI illnesses, but also can cause respiratory illnesses. And in mid-August, particularly in Missouri, but then spreading throughout the Midwest, they were noticing a really high rate of kids being hospitalized with URIs, but then developing severe respiratory distress. And to the point that they were overwhelming the intensive care units, because there was such a high volume and a fairly atypical time of year for severe respiratory distress. This is from the CDC website, and the most recent data as of November 12th. Just over 1,000 cases now in 47 states, including Washington. In 12 children that have died, they have found the enterovirus. That's not conclusive that it was the enterovirus that killed the child, but it's one of the things that they're concerned about. It seems to have peaked, but we may see it come back. We really don't. Enteroviruses go up and down throughout the year. The winter typically is a more significant season for respiratory distress. And so the difference is that, if you tested people for enterovirus D68 3 years ago, you would have still found a lot, but you weren't finding the same degree of respiratory distress. And so something has changed in this virus in which it's causing severe respiratory distress. And the thing about enteroviruses, as opposed to, say, coronaviruses that cause the common cold, is that they just tend to be a little bit more persistent on surfaces, and can be spread not just by droplets, but by contact. And so this is not something that you're going to know in the field. The only thing that it just re-emphasizes how important hand washing is before and after every encounter. Questions about enterovirus D68? Pneumonia presents differently in different age groups. So newborns, poor feeding is really the clue. Feeding is one of the most metabolically demanding things that an infant does, and so they may have difficulty feeding because they're becoming hypoxemic. In infants, it often presents similarly to a URI. The clue that you're dealing with pneumonia versus a typical URI is some degree of hypoxemia and especially persistent respiratory distress or tachypnea, even after you've done other treatments. And so I've certainly picked up cases of pneumonia, just a kid who just has that persistently high respiratory rate. And you're not getting some of those other clues in the history that you would with an older child. And in children and adolescents, more typical to an adult presentation with fever, cough, congestion. So pre-hospital management is supportive. Occasionally there's associated wheezing that can be treated, and then IV fluids. And then finally, we're going to talk about pertussis or whooping cough. This is something that has become slightly more frequent over the last few years and has been causing more problems in the adult population as well, which then in turn causes problems in the pediatric population. So the key diagnostic feature of pertussis is that they have these paroxysms of cough. It's just this violent, frequent coughing, and they become so out of breath that there's then a whoop as they try to catch their breath again. And I've got a video of that. It's very contagious. It's spread by droplets, but the coughing is often so severe that they can get cyanotic and hypoxic during a bout of coughing. It's supportive treatment. But it's the way, particularly with an infant with suspected pertussis, if there's a suspicion for pertussis based on what the cough looks like in an infant, these are people who will get hospitalized, and we'll often treat the whole family with prophylaxis if the infant is diagnosed with pertussis. This is this is in the most children at the most danger for this in the first year of life before the immunizations have really kicked in. Becomes much more rare after the first year of life unless the child is unimmunized.
Fever and squamous symptoms started out like those of a typical cold.
He had a white nose and started having a little cough.
But over the next 4 to 5 days, Pedro's mom, Chelsea, says the cough got much worse.
It was nothing I've ever heard before. He was coughing and doing the whoop with his vomit.
And he couldn't catch his breath. When they took Pedro to the doctor, the coughing had subsided, so they figured maybe it was.
And so this is something that gets missed, and at the risk of sounding like a broken record, this often you will hear something that we don't get to hear, and so that you were able to hear the whoop with that coughing spell, and so that's something that's very concerning. The other parts in the history that are just the these frequent, intense bouts of coughing make pertussis different from other respiratory infections. Okay. Any other questions about respiratory emergencies before we move on to cardiovascular? Okay. So we're going to talk about septic shock, cardiogenic shock, and congenital heart disease. So septic shock in children can present just like septic shock in adults. And the clue on your pediatric assessment triangle is really the poor skin perfusion. And so the child will often be altered, but a kid who's septic often appears mottled, has decreased capillary refill, and then hypotension for age. So management is supportive. Aggressive fluid management is very important in these children. So unless you're dealing with a kid who has significant congenital heart disease, there is no downside to aggressive fluid resuscitation. And so if still hypotensive after your fluid boluses, then you can start an epinephrine infusion. But far and away, the priority with these children is aggressive fluid hydration. So cardiogenic shock in children does happen, obviously much more rare than adults, and it's most often in the setting of a congenital defect. Occasionally, it can be related to a rhythm disturbance. So infants in particular can get SVT and can have cardiogenic shock as a result of that. In children, young adolescents, you can have cardiovascular collapse from myocarditis. That's a viral infection, but then causes chest pain and can cause cardiogenic shock. And then it can be secondary to some other insult. So these, the key diagnostic factors for cardiogenic shock, again, are you'll often see not as much respiratory distress, but an abnormal appearance, abnormal skin color. And with infants, you can see sweating with feeding. That's particularly with infants with congenital heart defects. So the important thing to remember about congenital heart disease is that it comes in two flavors, cyanotic and non-cyanotic. And so these are the names of a bunch of different things that cause cyanotic heart disease. The most common ones are hypoplastic left heart syndrome. You may hear the doc refer to these as hypoplasts. And then tetralogy of Fallot is another thing that's fairly common. These are children who will typically have a surgery within the first few weeks of life. The others are rare, also require surgery, but even rarer than tetralogy and hypoplastic left heart. The key thing with cyanotic heart disease is to get some sense from it. Many of these are going to be diagnosed. It's very rare that you're going to make the first time encounter with someone like this. Many of these almost all of these are diagnosed prenatally. But it's important to ask what the baseline oxygen saturation is, because many of these kids tolerate an oxygen sat in the 80s, and their baseline oxygen saturation may be in the low 80s, sometimes even in the high 70s, and so that's a key piece of information. And you want them to be at the high end of their baseline, but you don't need to drive them up to 100%. So non-cyanotic disease, atrial septal defects, ventricular septal defects, PDAs. These are something that you can occasionally see the first presentation of, especially in neonates. So a patent ductus arteriosus. Occasionally, if they have something that's dependent on the duct and then it starts closing after they go home, they can develop heart disease. And we have good treatment for that. It's a prostaglandin. One of the key clues when you're dealing with someone like this is to see how they respond to oxygen. If you give a child no previous diagnosis who's hypoxic, you give them 100% FiO2, as close as you can get to it through a non-rebreather. Someone who doesn't have one of these ductal dependent lesions, their oxygen saturation is going to climb. But someone who has an undiagnosed heart problem, the oxygen saturation is going to stay low. It's on 100%, it's going to stay 80, 85. And so the response to oxygen therapy is a really important thing to document with congenital heart disease. Okay. So you're going to do the pediatric assessment triangle. As best you can, the likely underlying cause based on history, and then supportive treatment, noting the baseline oxygen saturation, and then looking for rhythm disturbances. And so that's the one that, so having the monitor on a kid with suspected cardiogenic shock can be really helpful because occasionally you can pick out, they may be tacking along at 250 or 300, but only be perfusing every other beat. And so if you just take a pulse, you can be misled about what the underlying rhythm is. Questions about cardiovascular? Okay. So we're going to move on to talk about febrile seizures, which is another thing that I think we're going to be seeing a lot of in the coming months. So febrile seizures can be simple or complex. So a simple febrile seizure is you need to have fever, and they need to be between 6 months and 5 years old for you to diagnose it as a simple febrile seizure. It's a single seizure, it's a generalized seizure, and it lasts less than 15 minutes. This is something where I often find that there's friction between pre-hospital and in the hospital setting because we discharge someone like, I was a simple febrile seizure. But the thing that in the emergency department we're not seeing is we're not getting there 5 to 10 minutes into the seizure. And so when you look at a kid who's been seizing for 5 minutes, you don't know if they're about to stop, and you don't know if they're going to stop at 15 minutes, and you don't want to wait until 15 minutes to decide to do something. So we get this, and so you're gonna treat based on the worst possible scenario. And so there are children who have had a simple febrile seizure who will get brought back code 3 and who will get Versed, and that's fine because it's not. You have to treat the patient you have in front of you with the information that you have in front of you, and it's not, we in the emergency department with the benefit of a lot of time may be able to make this diagnosis. But if you're seeing this illness early on, a simple febrile seizure looks a lot like a kid with meningitis and status epilepticus. So to make the diagnosis of simple febrile seizure, no underlying neurologic abnormality, and then fever not caused by meningitis or encephalitis. So again, that's often something that you won't know in when you're doing this initial assessment, because you're going to be seeing them either when they're seizing or in the immediate post-ictal phase. It's a simple febrile seizure has to be a generalized seizure. So this is whether you're seeing it or whether you're getting the description of witnesses, whether it started in an arm and then generalized or was generalized. The way we approach that is going to be very different, because if it started localized and then become generalized, we can't call it a simple febrile seizure, and that kid is going to get more workup. And then our treatment is directed as oxygenation management of the fever in a simple febrile seizure. So the short answer for what is a complex febrile seizure, it's any febrile seizure that is not a simple seizure. So if you don't have all of those things, you can't call it simple. So if they're outside of those age ranges, if they had a neurologic problem before the illness, if they had something different before the illness and they had a fever, that's the same. But if it's focal or if it's prolonged, or if they have another seizure without returning to their neurologic baseline, then that's a complex febrile seizure, and that's when we're going to end up putting these kids on some kind of anticonvulsant therapy, and so that's why that history is so important to making the diagnosis, and it has big implications for their treatment. Any questions about febrile seizures? Okay, we'll move on to trauma. This will be review. Okay. But remember that trauma is the biggest killer of kids. There are distinct mechanisms of injury, and in that you will often see neurologic and respiratory problems before you see significant hemodynamic problems, because children can compensate so well. So children have a larger head, smaller jaw, narrower funnel-shaped airway, softer cranium in infants and open fontanelles, and more of a dynamic cognitive development. Because of this prominent occiput padding under the body, can help to maintain that neutral position. So in children, you can have children, it can be more difficult to diagnose spinal injury because they're less likely to have bony abnormality. And so it typically takes a fairly significant mechanism of injury, but they can have neurologic deficits as a result of that, even without having fractures. Pseudosubluxation is something that we look at on the X-rays, where there's actually, if you were to interpret a pediatric X-ray just like an adult X-ray, you'd see a small gap around C2, C3, which is normal. So these can just be more difficult to interpret. We more often now are using CT or MRI to look at that. With respect to the pediatric chest, soft chest wall, so you're more likely to have pulmonary contusions than rib fractures. If there is a rib fracture, it indicates a significant amount of force, and then they'll decompensate very quickly from a tension pneumothorax. In the abdomen, the liver and spleen are bigger relative to the size of the abdomen, which gives a large space for blunt injury. The bladder tends to be higher, and it's more rare to have an isolated abdominal injury. So in children, obviously, you're using age-specific vital signs. The overall blood volume is smaller. The functional residual capacity in the lungs is lower. It will compensate for a long time, but then decompensate quickly. And so what you'll see is a slow climb in the heart rate before decompensation. The blood pressure tends to be maintained. This is the percentage of blood loss. So at 30% blood loss, you'll have a significant increase in the heart rate, but the blood pressure is often maintained until there's a rapid drop. So just serial monitoring of the heart rate can give you important clues. Thermoregulation in children is more difficult, and so we need to prevent hypothermia. We know that some of our children are working on catching up to adults in terms of their insulation with subcutaneous tissue, but they're still at risk. And so a few more key clinical differences. Larger tongue, so more likely to have airway obstruction without BLS airway maneuvers. A higher larynx. We talked about the larger occiput. Head injuries can be more common than torso injuries. The way that I think about this are that children are kind of like darts. And just because of that heavy head, they're more likely to hit that first, especially if there's a fall or an ejection. So here's the response, and then just remember to use some kind of length-based system to dose your medications and fluids. Any other questions about trauma? Okay. We'll talk about children with special healthcare needs, and then that'll wrap up the pediatric review, and then we'll take a break. So one of the most common reasons EMS is called for children with special healthcare needs is trach plugging. And it's typically with secretions, either just a result of their inadequate normal hygiene, increased secretion production that you'll see with pneumonia or an upper respiratory infection. And so you want to assess the tube position, suction the tube, and if the child does not improve, you may need to remove and replace the tube. Some of these tubes have a removable inner cannula, and often just by pulling that out, you can solve the problem, give yourself more room to suction. You can bathe that inner cannula in saline and get some of the gunk off of it, and make a significant improvement in the airway with that. But if you're not improving, you're not able to get adequate oxygenation through there, you conceivably need to replace the tube. But I just emphasize doing everything you can with good hygiene and suctioning to open the tube up. A gastrostomy tube is surgically placed directly into the stomach to give nutrition or medications. There are variations of that. So this is a G tube, which is the most common. Some kids also have J tubes, which go into the jejunum. The parent will typically know the diameter is another clue. It's occasionally, we often see these patients in the emergency department. Occasionally EMS is getting involved for just a G tube that fell out. And so it's obviously very helpful, even if the balloon is broken, to just have the tube so we know what else to order. If we don't have that specific tube, but we don't have something else, we'll put a Foley catheter in there. But our goal is to just keep that passage open. Central venous catheters, generally in kids who have these, who either have ports or the catheter, it'll be tunneled under the skin, and so there'll be a port coming out just under the clavicle, and then you'll see a tunnel going up, and it goes into the internal jugular. And so that can get infected. You can get an obstruction or a break in that tunneled wire. They can also get clots in the catheter. If there were no other access in a code situation, you could consider using these. But in general, because you don't know how well it's working down the line, now that we have IOs, I think you're in general much better off going for an IO if you really need access in a kid like this. And then finally, ventricular shunts drain excess fluid from the brain. You can often, so it's an important piece of history to get. You won't always feel them or see them, obviously. There's usually a button right around the site, and then you'll feel tubing. You can feel it in the neck as they come down, and then most of them are VP shunts, meaning ventriculoperitoneal, and terminate in the peritoneum. Occasionally, there are shunts that go into the pleural cavity, and all of these can get infected, can get broken. And so if they're not draining properly, then these children present with increased ICP. Usually starts with vomiting, headache, and then can move on to a blown pupil. These children can occasionally get very, very, very sick. So shunt obstructions and infections are medical emergencies. These it can be, as you're going to treat the acute issue first. It can be helpful to get them to wherever their neurosurgeon was, but first priority is stabilizing the ABCs. Randos. I don't. But is there anyone at Peace Health who does peds?
Yeah, nobody.
Yeah.
It's either Dornbecker or
Dornbecker or Randall. So, stabilize ABCs first, but these it can really help to get these kids to an area of specialized care. Now, if it's just if there's a minor issue or the shunt is one of the things that could be causing the problem, both of the hospitals in this county can do the initial assessment and then transfer them. But if there's a significant problem or you have a high degree of concern that the shunt is the problem, it helps to get them to where their neurosurgeon is. Okay. So to review management of children with special needs, the assessment is standard. The parents often are very helpful with these children. You'll meet the child at his or her developmental level and try to get back to their own physiologic baseline. And having the caregiver there is very helpful. So to review, we talked about the pediatric assessment triangle, respiratory emergencies, with an emphasis on bronchiolitis, asthma, pneumonia. Remember to carefully assess the degree of respiratory distress when you first see them, and then to document how they're responding to your interventions. That'll have a significant effect on their long-term care. With cardiovascular emergencies, septic shock, heavy fluids, with heart disease. Remember to assess what the baseline oxygen saturation is and to document their response to oxygen. With febrile seizures, get as much history as you can regarding the seizure. We understand that simple febrile seizures early in their course look just like complex seizures from meningitis. remember the key anatomic and physiologic differences in trauma, and then we reviewed the issues with special needs. So any questions right now? Okay, let's take a 10-minute break and we'll start back at 10 a.m.
Can we please get started again? I'm not clear before. The whole drive. Yes, I
So let's talk about Ebola. So to catch up, for the quiz, there's one item that I didn't cover as I was trying to keep the lecture short. But remember, with autism spectrum disorders, the behaviors are specific to the individual. So we're going to talk about Ebola. I'm going to give you some background, and we're going to talk about the principles that are guiding the way that we're responding to this in Clark County. And Dr. Bell is here from Southwest and can comment on their preparations. And then Dr. Bell will be doing case reviews. So we'll start with some basic background information. So Ebola is caused by filovirus. There are 5 species of this virus. 4 of them cause diseases in humans. It's called Ebola because it was first discovered in 1976 near the Ebola River in what is now the Democratic Republic of Congo. This is the 2014 epidemic is the largest in history, and we'll go into the details and why that is. So this is from the World Health Organization and data as of 14th of November. So this just gives you perspective on where this is causing problems and what we're responding to. So by far, the majority of cases have been in Liberia and Sierra Leone, with Guinea after that. There have been cases in other West African countries, in Mali, in Nigeria, in Senegal. Those are patients who are traveling from the areas that are initially affected. And then there have been cases in Spain and the United States. Now, this is the World Health Organization data. I'll give you some additional data from the New York Times using a slightly different case definition, but we'll talk about exactly what Ebola looks like outside of the country. But note that of the cases overall, it's about right in the range of 40% of patients who have contracted the disease have died. And so this gives context as compared to the previous outbreaks. And so this is the most deadly outbreak in history. What you'll notice, though, is that the percentage of people who have died from this disease of all the cases is much lower than in previous outbreaks. And that's probably the reason that this outbreak has been so large. Because if everyone who gets the disease dies very quickly, then there's not an opportunity to continue to transmit the disease. But because the case fatality rate has been lower with this, it's had more opportunity to spread. So it's in similar regions to the previous areas, but a much lower death rate than in previous. So these are the areas that are primarily affected. So Guinea, Sierra Leone, and Liberia. And all of these are all countries that have fairly limited health infrastructure. The other things that have been difficult about containing the outbreak are that there have been there's been a reluctance to seek medical help, both because in some early cases, healthcare providers did not use adequate precautions and did spread the disease, and also because of traditional fear of there are fears like if you just say the word Ebola, then you can get the disease, and there's and concerns about doctors. So this is a difficult disease to treat that's hitting in a very medically vulnerable area. So this is data on the people who have been treated for Ebola outside of West Africa. So keep in mind that this is a devastating outbreak and an enormous human tragedy. What we are tasked with responding with here it's the outer ring, the people in general who responded to this outbreak and now are returning to their countries of origin. So in terms of the cases outside of West Africa, the United States has had a large number of them. So note, of all of the patients who have been treated in the U.S., there are 2 patients who have died. This was the case who presented in Texas, initially was sent home from the emergency department. And it sounds like the travel history that was obtained by the nurse, the physician was not aware of, didn't act appropriately on that. And so this case has obviously concerned a lot of us, and we want to make sure that our response is better and that we're not making some of the mistakes that were made in this case. So 2 of the roughly 100 people who were involved in treating that initial patient in Dallas, 2 of them got Ebola. They were subsequently transferred, one to Bethesda, Maryland, one to Emory Hospital, Atlanta. And both of those nurses who were treating that patient in Dallas had made a full recovery. And so what you'll notice is that for patients who are treated in the developed world, the fatality rate is much lower. These are very small numbers, but we're looking at 10 or 20% with advanced medical care, and in hospitals that have done specific training in advance on how to care for these patients. There have not been cases where healthcare workers have been affected. So the cases where we have healthcare workers infected were in this initial hospital that was affected, and I think I think this hospital was not unreasonably caught by surprise and not prepared to do all of the things necessary to care for this. And then this summarizes some of the cases that are in other places outside of West Africa. So again, very small numbers, but a lower case fatality rate than we're seeing in Africa. So the symptoms are fever, severe headache, muscle pain and weakness, diarrhea, vomiting, abdominal pain, unexplained hemorrhage. Now, luckily, we don't see any people who have any of these complaints. Obviously, we're going to get a lot of people who have one of these symptoms. And so the key part in the screening is getting the exposure history. So the symptoms can come up to 21 days after exposure, and recovery is dependent on good supportive care. And then these patients have antibodies to Ebola. So transmission is through direct contact through broken scalar-mucous membranes with objects that contain the virus. You can also get it from handling infected animals, but I'm going to trust that that's going to be less of an issue here. And only symptomatic patients can transmit the disease. Now, clearly, it's not like some switch flips and then you're immediately symptomatic and you can immediately treat the disease. Any of us who have gotten sick know that it's a gradual process. And so take, for example, the doctor in New York City who had returned from treating patients in West Africa, and then he was out and about. No one was affected, no one contracted Ebola from the places where he was going out and about, but in an abundance of caution, those places underwent thorough decontamination. So, and Ebola is not airborne, so you don't catch it like you catch the cold. But that said, if someone's having explosive vomiting or diarrhea, frankly, it's less important to me whether that meets the clinical definition of airborne. We know that stuff is everywhere, and we want to take great caution to make sure that the healthcare workers are not affected. So the first step is screening. So we're going to ask, do you have any of the following symptoms? Fever, chills, headache, joint or muscle aches, weakness or fatigue, stomach pain, vomit or diarrhea, and abnormal bleeding. Clearly, many people will answer yes to some of those questions. And then during the past 3 weeks, have you been in an area where Ebola transmission is active and had contact with a person known or suspected of having Ebola? So this is clearly a moving target, and I'm going to talk about our principles that guide the response and then with the specifics of the protocol. So our key priority is maintaining provider safety. And so screening is the first step. And clearly this is difficult to operationalize. We can't grind our medical system to a halt because we've had 9 to 10 cases out of the 300 million people in the US, but we also can't ignore this. And I think the position that people who are day-to-day providing EMS care in is much more difficult because at least in a hospital, you have a fixed location, you have an immediate area set up where you can take them to. So, but asking these screening questions is the first step in making sure that we're identifying suspect cases. Now, CRESA is asking these questions with appropriate sick cases, but we all have been in a position where we got information from dispatch that wasn't complete or accurate before, and so you're gonna confirm and you're gonna do those things yourself. And this is not a time-critical emergency. On the contrary, being slow, deliberate, methodical is what's key here. Rushing, either not getting the screening right or not getting the PPE right, is what's potentially life-threatening to the provider. So it's a slow, deliberate process. And then, as with everything we do, but I think the risk is amplified here, we're going to weigh the risks of intervention against the benefits. So there are, I can think of very few of these patients who really need a pre-hospital IV. There are very few of these patients for whom intubation in a pre-hospital setting is going to be the life-saving step. And so we're going to minimize interventions. So if you have someone who is symptomatic and has a high-risk exposure, then you're going to establish protocol, establish fluid precautions, back off, consult medical control. the reason that we're saying this is that the case definition will change over time. If an outbreak moves to a different country, if, as we were seeing in the, first few days after the patient was treated in Texas, one of the people who had been involved in the lab went on a cruise ship. And so the case definition is going to change over time. And that's why we're asking that you involve medical control. We don't expect you to keep up with every permutation of the case definition, but before making a decision that has a significant operational impact, we're gonna ask that you get a physician to assist with that. You're gonna request a hazmat response, and then then that will allow for a slow, deliberate response following all of the guidelines for PPE. And then avoid invasive procedures or anything that's likely to cause blood or bodily fluids to splatter. So I mentioned IV airway, suctioning. Again, you want to minimize, and no nebulized medications. Albuterol is not going to make the difference in a case like this, and there's significant risk with that. So the principles of PPE is that it's a systematic and practiced process. It's driven by a checklist, and you have a trained assistant for getting the PPE on, and an observer who is watching the process and making sure that you're following the steps. So the specifics of what you use. So if you go to the CDC website, how you put this on, how you take this on, how you put this off, take this off depends on what specific equipment you're using. So some agencies are using N95 masks, some agencies are using PAPRs, and some people are using gowns, some people are using full body suits, and there are different individual steps for doing that. And so that guidance is going to be agency specific, but it must meet or exceed the CDC guidelines. So the key points, this is very rare, but we can't ignore it. The healthcare worker exposure has been in places that were not prepared and not following methodical protocol. So Dr. Bell went through something similar. All the legacy emergency department staff have also gone through specific training on how to don and doff this, and the hazmat teams have as well. Ebola is not airborne, but these patients do spray a lot of fluid, which is why we take such caution. And then there are protocols in place both for the hospitals in the county and at the health department. And so with that, I'll take any questions that you have. Okay. Feel free to ask any questions after as well. I know that this has been difficult to deal with, and that this will change over time. The last thing I'll say is the outbreak in Africa is probably going to be going on for at least a year. This is not something that's going to go away, and there will be other infectious diseases that will be called to respond to over time. So this is part of our mission, and it will not something that's going to go away in a few months. It's something we'll need to continue to be aware of. Thank you.
Oh, sure.
Hey, Marlon, give me 1 second.
Spacebar. Okay, good morning. We have a few cases to review here that are pertinent to Dr. Mock's review this morning in Pediatric Emergencies. Can you all hear me? How about now? Okay. There we go. Okay, this all brought back into my mind a case that I managed, I don't know, 15 years ago. That was a little kid that was brought in, I think, by EMS with respiratory distress. He's probably 2 or 3 years old and gasping for breath, and he was cyanotic and kind of really distressed. We quickly bagged him and up with some oxygen, suctioned him, looked in his airway, didn't see anything, and I intubated him pretty quickly. And shortly after intubation, out popped this big grape that had lodged in his proximal esophagus, and it reminded me how these kids can be so scary and so challenging, and then they'd be compromised by pretty innocuous things occasionally. So this is the first case. This is a code 3, and if you manage this case, ran on this case, it'd be helpful to get maybe your input for the others in the room. So it's a code 3 for a 5-year-old with shortness of breath. And this kid was in obvious distress, speaking one-word sentences. He had a history of asthma, apparently, and was obviously retracting and having a difficult time with his respiratory status. His pulse was 177, respiratory rate was markedly increased, and he was a little bit hypoxic, obviously trying to compensate. Here's the run summary. It sounded like he had diminished lung sounds and no obvious wheezing. Sometimes that can be a difficult thing to appreciate wheezing when they're really tight because they're just not moving enough air. And as they improve with treatment, then you can sometimes tease out the wheezing in the fields, and that's helpful to pin down the diagnosis. SATs, as we stated before, 94%. Is awake and alert at this time, but obviously distressed. Provided with oxygen and non-rebreather mask, and seemed to improve a little bit on that. And then for some reason get some racemic epinephrine. I don't know if you ran on this case, let me know if the thought was that there was some degree of croup. Doesn't seem to describe that here, but racemic epinephrine inhalation and nebulized treatment also provided some improvement. EKG was obtained and got sinus tach on the monitor. And so improved. Respiratory was down from 40 to 32. Heart rate was still high as transported to Salmon Creek. And I think in the hospital, this kid was found to have a markedly elevated white count of 47,000 and had a history of frequent ED visits and had some underlying immunologic disorder. Perhaps, I don't know. Do you have any other follow-up on that kid?
Yeah. No, there's the final. We don't have a final diagnosis yet. Clinically he was improving, and then he's undergoing more testing to figure out why he's been getting these frequent infections.
We see a lot of patients with bronchospasm in the county, whether it's asthma or whether it's reactive airway disease because the parents smoke 2 packs of cigarettes in the house a day, or it's with chronic bronchitis in their cases. But the treatments we have are pretty effective with nebulized bronchodilators, steroids, and as Dr. Mock said, applying the pediatric assessment triangle on these kids when you arrive and see their appearance and their work of breathing and their skin color. Sometimes they can be cyanotic or diaphoretic pale. So that's a really good assessment tool and kind of judging how severe this is and how aggressive you're going to need to be. Sometimes they need to be intubated if they don't respond, and it can be. We try not to intubate kids when we don't have to because intubation has its downsides with the trauma to the airway, and it sometimes can be a difficult time just kind of experiencing that. So case 2. This is a 3-month-old with shortness of breath, and this is again a kind of reiteration of what Dr. Mock had talked about in his discussion on Croup. Woke prior to calling with significant difficulty breathing, and there'd been a virus in the house for several days. Had audible stridor, was crying, and had a seal bark-like cough, kind of characteristic of upper airway obstruction. Thick green, I guess this was Mark Muir's description, snot, okay, coming from the nose while crying and coughing. Here's the summary. So there was some wheezing audible in this particular case in the lung fields, and also as depicted the respiratory distress, tachypnea, and tachycardia. Got nebulized racemic epinephrine, which is appropriate, and had a decreased work of breathing, which is good, and was transported to Salmon Creek after the hospital, pre-hospital racemic epi. The stridor had largely resolved, got dexamethasone. Typically we give that orally now, I think, and it's been shown to be pretty effective in preventing recurrences and trying to educate the parents on discharge of them. Sometimes they're severe, sometimes these kids need to be intubated too. I mean, we've had, especially, this is a kind of a physics equation, because the smaller kids have more difficulty with this upper airway obstruction because they have not much room to play with there. They get swelling and mucus production, and they can get into distress really quickly. So this kid was observed for several hours and didn't have a recurrence of symptoms and was discharged and managed appropriately. And that's often the case. I mean, we can manage most of these patients as outpatients. There's an occasional anxious parent or severe distress that will require admission. And this one, I'm going to ask Dr. Mock to weigh in on this one after we go through the summary. This was a devastating case, code 3, and I don't know if any of you were involved in this one. It's a 1 month old laying supine on the floor in the bedroom, call for a cardiac arrest, with the mother attempting to do some CPR. The story was that the child was not acting or breathing normal. It was an evening call, recently seen by the PCEP for some congestion, and then the call was started after the child wasn't breathing. It was a premature kid, apparently by birth. Here's the run sheet. So there was no respiratory effort. Apparently, a bag valve mask was started, and there was a pulse of 140, brachial pulse. Chest compressions were started after the heart rate fell appropriately. I mean, when the heart rate falls below 60, you should really start compressions. And in these, this age child, and I think an IO was inserted. Maybe it's on the next sheet. Here we go. Intraosseous proximal tibia on the right. This can be difficult in a 1 month old. It's a small little bone. So, and then epinephrine was used at clinical interpretation PEA, continued CPR, intubation. This was a 3.5 straight blade Miller, 1 attempt. And I can't tell, was this successful?
No.
So not successful. Bag valve mask. So that's these can be very difficult intubations. So I mean, if it's you don't have a good look at the epiglottis or glottic opening. You don't want to do a blind attempt at this because it can cause more problems and go back to bag valve mask and continue supportive care. So parents were calm and not able, and this has been my experience with these kind of cases in the past, that there's kind of an odd reaction to this devastating thing that's going on. Parents were apparently calm and not able to provide EMS with much information pertaining to the events, so not very forthcoming, which is a little concern. I mean, so did this kid come to Southwest initially?
He did.
He did?
Yeah.
Yeah. Okay. Because I didn't actually see the Southwest phase, but then was transferred to Randall. And CT apparently showed some pretty extensive brain trauma, and there was an expiration. So non-accidental trauma in this age group is something we all fear, and we don't, this is the worst type possible call you can run on, I imagine. But we see it yearly, once or twice, and it's just a horrible thing. But things to get are, from the pre-hospital standpoint, or some of the history, and if you have an odd feeling about things, it's really good to pass on to us and increase our sensitivity for pursuing an accurate diagnosis. Do you want to talk any more about that particular case, or?
I mostly wanted to say the crew did an excellent job of documenting this. I mean, there's a very, very good pre-hospital care and very good documentation. Specifically, they documented the objective things that they found. So there was no response, no lights on at the house, no response for 2 minutes after they knocked on the door. The family was not able to provide the additional history. So there wasn't supposition, but a really accurate description of what exactly they saw. So it's just a very an unfortunate outcome, that was well cared for in the pediatric setting. And these cases are humbling because even in the case where the kid's in cardiac arrest, you don't have obvious signs of head trauma, and these can be easy to miss. And so, particularly when you see vomiting without diarrhea. If there's any, these cases are just really easy to miss. I have missed them in the pre-hospital setting before, and so you just need to maintain a really high index of suspicion for non-accidental trauma, because the outcome can be devastating.
And here is case number 4, and I think this is the last one. This was a seizure case, 1-year-old. Had a seizure 5 minutes prior to EMS call, fire arrival. Patient had a second seizure, grand mal, lasting a couple of minutes. Patient had a history of seizures and had been on medication, including phenobarb and Topamax, it looks like. Was given 135 milligrams of phenobarb IM prior to arrival. And last seizure was 2 weeks prior. So this kid had some major problems with kind of managing these seizures. Child was lying in the left lateral on the position on the floor, crying with minimal movement. En route in the ambulance, began to seize again, mostly on the right side. Lasted about 8 minutes, given some IN Versed, and some supportive care for respirations. So here's a little review of their estimation of the mental status with a Glasgow of 9, mentioned there. SATs that decreased and then improved. Check of the glucose, which is always important. I mean, you never want to miss a hypoglycemic kid, especially with a seizure. They have a lot of metabolic activity during that event. They get really acidotic. They get hypoxic. They can burn up glucose. They can produce a lot of lactate in that anaerobic state. So that's the way we see it in their metabolic profile when they come into the ED.
they're usually very acidotic and they have a high lactate, and with that kind of history. So with seizures, they typically will have inability to control their respirations, and they'll get hypoxic. They may have lots of oral secretion, so you want to provide suction and protect their airway and provide supplemental oxygen and assist them if they need it with a bag valve mask is appropriate, and not necessarily attempting intubation unless it's just kind of status and you need to intubate, so they get paralyzed and intubated. And it's important to give the history that there's ongoing seizures, because when you're paralyzed and intubated, we don't see seizures. We need to address those as well and assess the fact that they may have ongoing status. So in the hospital, this visit had a fever and maybe a little pneumonia on chest X-ray, empirically covered for that with antibiotics, and recovered well and discharged at home with chlorazepate to keep seizure threshold low during the infection. So the kid's on a lot of different medications. Any questions or comments on these cases or anything Dr. Mock had covered? I know that's a lot of material and it's a good review. Thank you very much for the excellent review. Yeah, it's awesome. So, all right.
Great. Thank you.